Have you ever wondered what the difference is between psychiatry and neurology? You might think it's a huge difference. You have these two different types of doctors, massively different training, different approaches to different illnesses, mental illness versus a neurologic illness. But you might be surprised that there's much more similarity than there is difference. Today, we bring an expert, a mind master, Dr. Sarah Lidstone from the University of Toronto, who studies neurology, but is in an amazing field called neuropsychiatry. And this is a field that combines the practices of neurology and psychiatry, the hardware and the software of the brain. An incredible discussion with a leading mind in neurology and bringing in psychiatric approaches to solving very complex issues with the human mind. Welcome to Beyond the Checkbox. We're excited for you to listen to our Mind Master series. And today, Dr. Sarah Lidstone is leading the charge. I'm Dr. Ryan Todd, a psychiatrist with over a decade of experience. And in this series with leading experts, we will explore the complexities of mental health, breakthrough therapies, and today's hottest topics. This is Beyond the Checkbox Mind Masters. Tell us what you do. Like, what's a day look like? What kind of patients are you working with? What kind of research are you focused on? Because it's morphed over the last many years since we've known each other. So what does a day look like? What kind of stuff are you working on?
So I'm a movement disorders neurologist. So I treat patients that have problems with their movement. And over the years, as you mentioned, it's evolved for sure. I do a lot of neuropsychiatry now, which basically looks at a whole brain perspective around people that have problems with movement. And the population of patients I deal mostly with are patients that have something called functional neurological disorder, or FND. It's the most common neurological illness you've never heard of. So this is when people experience problems with seizures, with weakness, with their walking, sensory changes, and we can't find anything on an MRI. So there's no structural problem that we can see. And so it's the second most common reason to see a neurologist, actually, and it's a hugely common problem. It generally involves patients in midlife, so 20s, 30s, 40s, 50s. They're at the prime of their working career. They have families, got a lot of balls in the air, and then they can be struck one day and be paralyzed from the waist down. And so it's a really fascinating condition, and it's a really rewarding place to practice because it really lies at this intersection of mental and physical health, and challenges us as physicians to look at a whole brain perspective. So that's what I spend my day doing. I spend my day watching people and trying to understand what makes them tick. How is it that they're in my office with spasms all over their body and not able to speak to me some days? Other days they come in and they're completely better. And the symptoms do this all the time. And so it's a really interesting population to work with.
Like, just to break it down, what's the main difference between a psychiatrist and a neurologist?
Yeah, so at the highest level, I mean, psychiatrists are trained to essentially, I mean, I'm speaking to a psychiatrist and you can correct me, but
Well, you're more eloquent.
administering, essentially arriving at a diagnosis for what's contained in the diagnostic and statistical manual, the checklist of mental health disease, to diagnose patients and to manage them, mostly primarily with medication, although also other therapeutic techniques are often used. But it's really quite different from neurology. In neurology, what we are trained to deal with is when something is broken in the nervous system. So somebody has a stroke, or they have a tumor in the brain, or they have a spinal cord injury. And so we're able to find the problem that is broken that explains the patient's symptoms. And when I was trained as a resident, you and I trained together, it was very much around what is the lesion, where is the lesion, and that determines treatment. The problem is, like most of neurology, there is actually no lesion. And so this artificial distinction that we've placed between what constitutes a quote unquote psychiatric problem and what constitutes a neurological problem, in my view, it is totally artificial. There's actually no boundary that's there. And the more and more that we learn about how the brain works, the more and more we're finding that that framework of separating these two disciplines completely does not help patients, does not help outcomes, is very challenging to work with as a physician, actually. And the system is utterly not set up to manage these types of conditions.
Yeah, that's really interesting because we during our training, this sort of hardware, and you talked about this in your TED talk, hardware, software, and neurologists deal with the things that you can see that show up on an image, and where is the lesion or the insult in your brain that you could point to. And then psychiatry was sort of everything else that you can't see. And what you're saying is that's not helpful anymore. There's really no difference. Um, and it doesn't help patients because they come in and they have a set of symptoms. Is that a fair assessment? Like the hardware software thing is the more we understand these two fields, it's kind of broken down and it doesn't hold water anymore.
Yeah, I think it's highly complex, right? Because you can have a problem with the hardware that then turns into a software issue afterwards, and vice versa, right? You look at migraine, it's all software. We do an MRI, we can't find migraine on an MRI, and yet millions and millions and millions of people suffer from headaches. They get, visual loss, they get weakness on half of their body, numbness and tingling. They have symptoms that are genuine and real they're experiencing, but we can't find the problem. And so, there's this tendency in medicine to, well, if the test is negative, so like the blood test doesn't show anything, or the X-ray or the CT or the MRI doesn't show anything, then the problem can't be real, right? It's not a real problem if we can't find the structural reason.
Send them to psychiatry.
Exactly. And so this is where, and then but the patient feels the symptom in the body, and they're like, I don't need to see a psychiatrist. Right. So they arrive in a psychiatrist's office and they don't want to be there at all. They don't think they need to be there, which is, I think, quite a reasonable, impression for them to have.
No one wants to see us. No one wants to see
Oh,
us.
and then you're
It's
also
very
dealing with
reasonable.
the stigma as well, right? So it doesn't work. It doesn't work as long as we're not talking to each other. We're operating from these models that, in my view, are highly outdated. And it's the patients who suffer, and also the physicians, because they don't feel they have the skill set to be able to treat people well and get the outcomes they want.
Do you think it's the case that we just don't have the technology to find the lesion or the thing? Like if we had a better, more magical MRI that we could see migraine headaches on that, or, we could see depression on that image, or we could see anxiety, like presumably, there's something physical and seeable going on there, but we
Mhm.
don't have the thing to see it yet.
And you can certainly make that argument. People do that all the time. And back in my field in movement disorders, there was this. We're still operating to some extent under the legacy of Marsden back in like the 50s and 60s, and they were trying to characterize dystonia, right? Dystonia, which is these spasms people get in their body, their muscles go into these postures, was largely seen as a psychiatric or psychological problem. And in fact, a lot of these patients had what ended up being these genetic disorders, inherited conditions, these rare mutations that would cause these dystonic phenotypes. And so the pendulum swung all the way, being like, oh God, all dystonia now, it's not quote unquote psychogenic. There's a real reason these patients have these problems. And so it's kind of this back and forth thing. But I think regardless of, and MRI does have some correlations that we can see for migraine, for example. So does depression, so does anxiety. We do see morphological changes on MRI if you compare people who have those conditions to healthy controls, for example. More functional based studies looking at things like functional MRI, for example, can show some changes. But there's a difference between using that technology to diagnose the problem and then what do you do with it? Right. So what I really care about is the treatment, right? Because I do rehab. I'm a neurologist who does rehab. And the rehab is looking at that intersection of mental and physical health in the room at the same time. And I I really do think that we've become so reliant on these biological markers to indicate that the problem is actually real. Even if we do develop those for, let's say, anxiety and depression, what do we do with them? Right? We still have to help the patient. We still have to get that patient to a place where they can function, where their symptoms are better, where they feel better and they're healed. And so I don't, I, it's, there's two different parts of what you're talking about.
And the thing about is it real or not is a really I think it's probably the core of it, right? And where patients feel the most frustrated because they're experiencing very real things and they're told tons of different messages on is it real or not? Like can we see it on a picture, or do you have to go see psychology or psychiatry because it's all in your head? And so you're working at that nexus between the hardware and the software and that kind of emerging field. Is there new research to suggest that that doesn't hold, like it doesn't apply anymore? Like we could throw that model out? Or is it just simply that you see patients suffering and you're trying to figure out the best ways to help them?
Well, what you're fundamentally talking about is this, where this conversation began. There's this, it's a tendency to fracture the brain in this dualistic model where it has to be all something that's non-lesional, i.e., invisible or like quote made up, right? Is the implication there, or it's all structural, real. We can see this, we can treat this, we can put a cast on it, we can give you medication for this problem. And that is it's a remarkably unsophisticated perspective on brain function. Like we know so much better than that based on all the research that's been developed over the last, 50, 80 years and the advent of brain imaging especially. And yet it's not trickled down into actual practice. We still tend to have to lump people into one way or the other. And I think that's historical. I think there's a massive, really interesting kind of historical legacy around that. And it's also the fact that our health systems are so slow to change. Our training is so slow to change, right? You
Yeah.
came up as a psychiatrist, I came up as a neurologist. At no point did I ever have a single lecture on functional neurological disorders in my training. I gave the first one at University of Toronto.
Say
We're
that again. You
so
were the first, like, okay, and we're talking just for more context here. This is one of the like most prestigious, oldest neurology programs in the country. And this is the second most common neurological disorder. And you didn't have any lectures on it during training.
nope,
Whoa.
nope. No, it was brushed up against when we talked about epilepsy and other things, and we included it on the how we approach medicine with the differential diagnosis. When somebody comes in with something, what are all the different options that it could be? It was kind of an afterthought that was mentioned as well. Always think about this. Psychogenic, it's not real. Send them to
Yeah.
psychiatry, right? And
But
the
it was
same for
kind of like you were
psychiatrists.
giving up, though. I kind of got the sense that you were like, it's last on the differential because you want to rule out everything else because you sort of give up. And then we're going to
Mm-hmm.
put it in that bucket of like,
Mm-hmm.
it's all in your head.
Yeah. So it is an outdated model, right? It doesn't work and it doesn't serve patients. And you know, I've been thinking a lot in preparation for speaking with you today about how this type of work relates to the workplace, for example, right? And what I do all day long, really, to like circle back to your earlier question, even was is that I built a clinic where I see a patient at the same time as a psychiatrist and at the same time as a physiotherapist in the room at once. It takes longer, right? That's an hour and a half we're spending with the patient together. But Ryan, like the amount of richness that's added to the story is like absolutely astounding, right? That experience really changed how I see human beings actually and brain function. Because again, all of medicine is really about pattern recognition. It's about if what I'm seeing fits a specific pattern, and then that has to be the answer. But over time, what happens is you end up only looking for the patterns that you know. And
Mm.
it's very hard to see things outside of that, right? So imagine then seeing a patient in front of you, and I have a psychiatrist next to me who is unearthing the entire personal history of what this patient has gone through. The fact that they grew up in a household with an alcoholic parent who was super unavailable and really volatile, and they were always on high alert and vigilant to make sure nothing was going to hurt them. And then started to develop, migraine headaches at age 15, 16 years old, and then started to develop, symptoms of irritable bowel syndrome in their 20s, and then began their interactions with the healthcare system that were looking for the structural problem, doing all the blood tests, looking for the cause of the pain, not being able to find it, being told you're making this up, it's all in your head, and so forth. And what ends up happening is this, longitudinal perspective on what that nervous system has seen and experienced profoundly affects how that person will approach their body, how they interpret their body signals, how they then choose to interact with physicians and other healthcare providers.
Mm.
And so you can kind of see how it all weaves together into like this new thing that's not structure or function, it's actually always both, because our brains are super complex. And often you have to actually go back to these really early experiences. And then what's really interesting and what emerged in our clinic and we've written and published about is then you begin to see these new patterns that are coming up, right? So in our patients, we see traits. It's all traits. So traits of perfectionism, traits of hypervigilance, traits of a hyper-aroused nervous system, traits of avoidance, coping styles that are really unhelpful, worked really well when they were younger, not working so well as an adult. We see a loss of agency, right? And so there's this deeper frequency of traits that, and here is where our earlier conversation around this split becomes actually, I think, really important, is because psychiatrists often don't look for those either. So the neurologists aren't looking for the traits, psychiatrists aren't looking for the traits, but this is where the meat of what's going on is. This shows up in the workplace, it shows up in HR departments, it shows up in family court, it's showing up in all of the institutions that are set up, and no one is actually seeing what's going on here.
Can you help us define traits a little deeper? Um, are you born with these ways of coping, of dealing with the world? Do you develop them over time? You're saying that there's a record, like your nervous system is almost like a book that you have to read to understand what the next chapter will bring. Are traits those things that those chapters in the book? Are they the ways of being and coping with the world?
I mean, here's where I would love to hear your thoughts also as a psychiatrist, because I always joke to people that I know enough psychiatry to be dangerous. Not a psychiatrist myself, but the way that I look at traits as a neurologist who specializes in kind of neuropsychiatry and these overlap conditions is things that are in the soup that don't rise to the level of being a pathological diagnosis that a psychiatrist would point out, right? So perfectionism, right? That's not really a disease. You don't get like put on medication for being a perfectionist, right? But it's a pretty stable behavior pattern and coping pattern and coping style that's arrived over time. So I do think a large portion of traits evolve as somebody just interacts with the world from pretty early in childhood. We don't, there's obviously data around kind of epigenetics and genetics around this. So genes you inherit, but the genes you also inherit that could be turned on and turned off based on the environment you're in, a lot often related to trauma. So I think it's highly, highly, highly complex, but kind of very basic bones. It's factors that contribute to somebody's personality and how they interact with the world that they learn over time, in the most part, but could also be inherited as well.
Yeah, I love that. So the factors that are developed over time that create who you are, the person that you are, and you can also see in your experience how these things are helpful, and then how they can also contribute to something that's really harmful is the wrong word, but something that becomes not functional. Like you could
Yeah.
see how competitiveness or perfectionism could lead to really good outcomes in the workplace. It could also, over time, with the right conditions and the right stressors, could lead to something like having migraine headaches. You could totally see that connection and understanding somebody's traits. Is that the core of what you're doing then, when you're seeing a patient with a physiotherapist, a rehabilitation specialist, a psychiatrist, that whole group, is to understand the soup, the traits that make up their personality, so that you can figure out how to actually treat this relatively unknown and emerging space? Are you trying to
Yeah.
understand what traits they're working with?
Yeah, and I think, traits, as you say, there's none of these individually is like the pathology, is
Yeah.
the disease, right? And and not all traits are bad, sort of quote unquote. It really depends on the degree of kind of helpfulness to you. And I think the other one caveat I will mention is that these are very often unconscious patterns. It's not that the person is kind of waking up and thinking, I'm a perfectionist, I'm going to go out and do my perfectionist things, right?
Yeah.
These are very unconscious patterns that develop over time. And so the work that I do, and what we've realized, that all of this focus on traits I'm talking about, I mean, the reason it came out is we were asking ourselves, what are we missing here? What are we missing? Why aren't patients getting better that have this problem? What are we missing as a neurologist? What are we missing as a psychiatrist? And how do we find what's in this gap? And after seeing many, 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 many patients in this new model of longitudinal, like looking at their whole, essentially what their nervous system has been exposed to, we did see these patterns and these traits rose to becoming very important. And so the work that I do actually is a lot of the work I do is what we call triage. So we're looking to see who can we help with the therapies that we offer, right? With the physiotherapies that we do and also psychotherapy. And sometimes we combine both of those together in real time as well. And those models, believe it or not, it's not this magical treatment. I don't come in and have this magic wand and say, we're going to fix you and you're better. In fact, what we learned is by looking at these traits and what's relevant for therapy, not everybody's actually ready to engage. And only about 40% of people are there. They're at a place where they can benefit from the tools that we have to offer.
What did the other 60% do?
Yeah. And this is, I think, what the healthcare system and physicians really struggle with is the chronic illnesses that again kind of fall outside or adjacent to, they're more test negative types of conditions. Chronic pain, for example, chronic fatigue is another example. Parts of functional neurological disorder I mentioned, irritable bowel syndrome, right? There are functional conditions as part of every subspecialty of medicine, and there's a lot of chronic illness in there. And what we see, at least in our data, which only applies to a subpopulation of them, is often there is an agency deficit, is a really big pattern that we see. So
Is there other agency deficit, like they don't feel like they have control over their life?
yeah, there is a perpetual sense of victimhood, that things happen
Mm.
to them. There can be a helplessness that's there, and a low locus of an external locus of control, where it's these are things that have to help me, and that individual doesn't feel they have the tools to help themselves.
I don't make things happen to me.
Yeah,
Okay.
and it's kind of a way to go through the world actually. So, and this is where I think this whole trait discussion is really meaningful. It's that it doesn't only come up in one situation. It actually is how that person interacts with the world. And so we do, say, I've had colleagues who say this, and I have as well, that the lesion, there is a lesion, but it's between the patient and the system, between the patient and the physician. That's where the lesion is. It's a relational disorder.
Interesting. I think this is so applicable to the workplace because you see chronic fatigue, you see irritable bowel syndrome, you see migraine headaches, you see these things that don't have a picture, that impact people every day in the workplace, employees, people like you and I, and it all happens on a spectrum of stigma. Like it's relatively accepted having migraine headaches. I would say there's zero stigma around migraine headaches. I would say there is a massive amount of stigma around, maybe not massive, but there's way more stigma around chronic fatigue syndrome. Like there's way more attribution that like that this is that person's fault, or you did something, or you're weak. Like all those constructs. And I don't think that people have a great way to deal with them, again, because there's no picture. There's no lesion. And what you're saying is the lesion isn't in the brain. It's in the system, and it's how we understand it, and it's how we are relating to that individual.
I think that's one really meaningful level. And I chronic fatigue is a really it's an area that I don't delve into. It's actually a very polarizing condition. There is a on social media, it's really active. It's a really active area of a lot of strong advocates, patient advocates who really fundamentally want and believe that there's something that's broken, because they've been so invalidated,
Yeah.
and they've been and I can understand that as well. But again, it comes back to this question of sophistication. We actually really know a lot about these patterns and how the brain works, and can design better systems, but that's not what the reality is day to day for patients right now. Um, and so we need to work really hard to figure out, and this is what your show is all about and your work is all about, is how do we integrate more sophisticated thinking about mental health across society, right? Not just the workplace. Um, because the more I learn about this, like, you are so spot on in the work that you guys are doing. There's this undercurrent always, this, as I said, this kind of deeper frequency that's there that comes up in all these different institutions that results in so much productivity loss, so much money being spent, right? Because the people who really struggle with this the most often occupy the most resources in an organization. So there's a lot of conflict. There's just lots. There's a lot happening in there.
I appreciate you joining us and helping us understand it and putting some parameters around it, how we think about it, the traditions and where this kind of dualistic system came to be. And also, I think there's a nice focus here on trying to understand traits and personality and trying to do that work ourselves to understand where some of these unconscious pieces came from. So super interesting. I think it is a incredible world that you're in. And it sounds like you've created a lot of it because there was no lectures that you had or no experts that you had uh, in your training. So, Sarah, thanks for joining us today. And it was an awesome conversation.
Happy to do it. Thanks for